We are attuned to look for ST elevation, but may not always see the STEMI equivalents. But if we recognize it, we could one day save a life, and hence this is very commonly tested in postgraduate examinations, including FRCEM. Wellens syndrome represents a reperfusion pattern in the setting of severe proximal LAD, left antidescending stenosis, when seen in an asymptomatic patient who was recently symptomatic. So critical LAD stenosis, but no infarction yet, of type 1 and type 2. So type 1 or type A has biphasic T waves, and type B has deep symmetric T wave inversions. Diagnosis requires preserved R wave progression, no precordial Q waves, minimal ST elevation, and the characteristic T waves in the precordial leads, typically V2 and V3. Treatment is coronary catheterization. Stress testing is contraindicated because of the high risk of precipitating infarction. So here we see the biphasic T waves in V2 to V4, typical of Wellens type A. It's just 25% of cases. And in Wellens type B, which is 75% of cases, we see the symmetrical, deep, negative T inversions. Here we see it in V2 to V3, which is a common area. Wellens progresses from pattern A to pattern B over minutes to hours, but often remains asymptomatic, but suggesting critical stenosis of LAD with a pending left antidescending with a pending large myocardial infarction. So pattern A with terminal T wave inversion, progressing later still with the deep symmetrical T inversions of pattern B. You admit serial ECGs and an inpatient cardiology consult and angio. Patients can be pain-free at the time the ECG is taken. Patients can have normal or only slightly raised cardiac enzymes, but they are at a very high risk of an extensive anterior wall MI over the next few days, and hence they require urgent cardiology review. Do not discharge. Speak to cardiology urgently. This is the importance of recognizing ECG changes. Here we see a typical Wellens syndrome ECG, the whole 12 lead. Now let's talk about De Winter's STEMI equivalent. De Winter's was described in 2008 by De Winter RJ et al. And occurs in around 2% of left antidescending occlusions, LAD occlusions, has 1 mm of upsloping ST depression, tall symmetric T waves, most commonly in the precordial leads, the chest leads, 6 chest leads, with no ST elevation, but there may be 0.5 to 1 mm per ST elevation in AVR. Here we see the De Winter's T waves. We see the upward sloping 1 to 3 mm of ST depression, followed by the tall positive T wave. The upsloping ST depression more than 1 mm and tall prominent T waves with no ST elevation and reciprocal AVR changes are again mentioned here with an illustration. Here we see some more ECGs, the De Winter's Wellens pattern B as a revision aid, Wellens pattern A as a revision aid with a biphasic wave. Even hyperacute T waves are something we may miss as a first early sign of an MI, of an ST elevation MI. If we're just looking for ST elevation, we may miss hyperacute T waves. So apart from Wellens and De Winter's, we've now moved on to hyperacute T waves. We'll talk about northern OMI, which is any ST elevation in AVR and AVL with a negative T wave, with reciprocal ST depression in 2-3 AVF or V4 to V6, precordial swirl. ST segment changes, swirling across precordial leads. ST elevation in V1, V2 with ST depression in V5, V6. The Aslanger pattern, which is any ST elevation in lead 3 with ST depression in any of the V4 to V6 leads with the positive or terminally positive T wave. The ST elevation in V1 is higher than that in V2. A new onset bifascicular block, which is right bundle branch block plus left anterior fascicular block, which would be RS complex in 2 through AVF, QR complex in AVL. The terminal QRS distortion can occur in anterior MI. An absence of S wave and J wave in either of leads V2 and V3. Posterior OMI. Maximum ST depression in anterior precordial leads. Again, it's not a classic ST elevation, so even a posterior MI may be missed if you are just looking for ST elevation, because you're actually going to find ST depression in the anterior precordial leads, and you need to do the posterior ECG to find the elevation. The South Africa flag sign signifies a mid-anterior high lateral MI due to occlusion of the first diagonal artery D1, which is a branch of the left anterdescending. D1 supplies part of the anterior wall of the left ventricle and its basal or anterolateral areas. So you can see on the 12 lead ECG, you have ST elevation in 1 and ST depression in 3, which you see is forming part of the South Africa flag on this picture. You then have ST elevation in AVL and ST elevation in V2. So this forms the green part. 1 and 3 form the 2 legs of the flag, and then AVL forms the central part, and then V2 movement to the green part, and then above you have ST elevation in leads 1, AVL and V2, with ST depression below in just V3, and these 4 territories are affected, which is in the shape of the South Africa flag, and hence it's called the South Africa flag sign of mid-anterior high lateral MI due to the occlusion of the first diagonal artery. So you might get 12 lead ECG with these changes, and if you find the South Africa flag sign, you know it's this first diagonal artery occlusion. Very often high lateral infarctions are not diagnosed on time, even by experienced emergency doctors, due to the non-contiguous nature of ST elevation on the ECG. And remembering the South Africa flag sign can help us pick these up. We see on this diagram the diagonal arteries and where they are. And based on this figure, it's easy to recognize why STEMI D1 is characterized by ST elevation leads 1, AVL and V2, and ST depression in 3, and sometimes, I didn't mention before, sometimes AVF. You can see the vectors. So if D1's affected, then we see the vector change as per this diagram, causing these changes. Thank you for listening. These are some STEMI equivalents. Picking them up could save a life.